Shui, what are your thoughts in terms of how we should be approaching lowering LDL cholesterol in relation to the different types of stroke or stroke mechanisms? Do you think that we should be more aggressive in certain types of stroke? Or do you think it's sort of like one single approach for all stroke?
Yes, I think it is a very good question. So as we know, so if patients have large artery atherosclerosis, we will give aggressive lipid lower therapies, and we will give a combination therapy. So personally, I will add PCSK9 inhibitor to the patients, in addition to statin therapy. So for the patients with small vessel diseases, so we should give a more detailed clinical classification. In my hospital, we will perform high-resolution MRI to the patients to see whether there is a non-stenotic intracranial plaques. If the patients have non-stenotic intracranial plaques, we will also give aggressive lipid lower therapies. If the patients don't have any intracranial plaques, including stenotic plaque or non-stenotic plaques, so only small vessels, cerebral small vessels are involved, we won't give more aggressive lipid lower therapies to these patients. For patients with cardiac embolic stroke, so we will respect the opinions of the cardiologists. Some patients also have coronary artery atherosclerosis, so they may also give aggressive lipid lower therapies, including PCSK9 inhibitors. But I don't know in Australia what's the condition. Sometimes the cardiologists are more conservative than neurologists. It's very strange. I don't know whether in your experience you do have the same impression.
I think that my cardiology colleagues are as aggressive in terms of how they manage dyslipidemia in their group of patients. But I think there are really interesting points that you've brought up in terms of when we think of it as atherosclerotic disease, whether that's large vessel or small vessel, I think that the approach would be the same, that you would be aggressive about lowering total cholesterol and LDL cholesterol. So the whole thing about, aggressive statin therapy, using other measures, and then thinking about using PCSK9 inhibitor if it's required. When I was looking at some of the previous studies, it was actually very interesting for me that in Sparkle, they actually excluded patients with atrial fibrillation. So the Sparkle trial is not really something that could be applied in that sense to patients with atrial fibrillation. Except, however, as you said, where there is significant atherosclerotic disease within the heart as well.
Yeah.
And in that sense, I think I would be aggressive in terms of treating patients. Speaking about, atherosclerotic disease, we are talking about, brain, we're talking about heart. What is your approach to say someone having atherosclerotic disease in the brain, large vessel, not really occlusion, not really significant stenosis, but then based on your evaluation, having, say, peripheral artery disease as well? What would you do in terms of how aggressive would you be, rather, in terms of treating their cholesterol?
Yeah. So if we go with the guidelines, so Chinese guidelines, the target of LDL-C is 1.8 millimole per liter. But for me, so as I have said, I am more aggressive. So in patients with intracranial symptomatic intracranial atherosclerotic stenosis, so after we give the combination of statin and maximum statin and PCSK9 inhibitors, the LDL-C will be reduced to 0, so as low as 1.3 millimole per liter. So I think sometimes it will scare cardiologists. They are not so aggressive. But for me, so after I give these treatments, it's safe. So it actually it's also surprise. So for me, so at the beginning, I'm also surprised to see that the very low LDL-C level is safe for patients. Actually, I am scared as well at the beginning. But after the observation of my after some patients successful treatments for the patients, I do think that very low LDL-C level is also safe. So just now I have said that sometimes I'm more aggressive than cardiologists. That's because if they go with the guidelines, so I mean the cardiologist guidelines, they will reduce the LDL-C to 1.4 millimole per liter, but they won't give a more aggressive treatment for patients with LDL-C level lower than 1.4 millimole per liter. But I will give treatment.
So I guess it's probably safe to say that how aggressively we treat LDL-C and cholesterol levels would depend very much on, as stroke neurologists, what sort of stroke it is we see. Is this atherosclerotic disease, large vessel, small vessel? And then from there, looking at the patient's other comorbidities in terms of whether they have heart disease, whether they have peripheral artery disease. And then in the setting, as you said, excuse me, of patients who have atrial fibrillation, what is the mechanism of atrial fibrillation? Mm-hmm. And how much does their underlying cardiac disease sort of come into play as well? And then sort of tailoring how low you want the LDL-C to be based on the patient's risk factor profile and what sort of disease they have.